Hello and welcome to the Clinical Care Options podcast. I'm your host, Zachary Schwartz. In this series, we explore challenging cases in primary biliary cholangitis. Today's episode asks the question, when should we move from first to second line treatment? How should we define treatment response? To answer these questions, I'm joined by Dr. Alan Bonder from Harvard Medical School in Boston and Dr. Aparna Goel from Stanford University in Palo Alto, California. To download the slides you can use to follow along with this podcast, please visit clinicaloptions.com or go to the show notes for this episode. Now let's get started and hear from our faculty.
Hello and welcome to this Curbside consult in primary biliary cholangitis, where we'll be focusing on defining non-response to PBC treatment. I'm Aparna Goel. I'm a clinical associate professor at Stanford University with an interest in autoimmune liver diseases, and I'm joined by my colleague, Dr. Alan Bonder.
Dr. Alan Bonder. I am an associate professor of medicine at Harvard Medical School, also with a research interest in autoimmune liver disorders.
So in a short case study, we'll explore how we manage a case or a patient that has primary biliary cholangitis. So we have a 35-year-old woman with hypothyroidism, a history of abnormal liver tests for the past 5 years. She's also been diagnosed with hyperlipidemia and has been on a statin. Her primary care provider has diagnosed her with steatotic liver disease due to metabolic dysfunction-associated steatosis and has advised her to lose weight. But despite having lost weight, there's been no real changes in her abnormal liver tests. She was subsequently referred to a hepatologist and was diagnosed with primary biliary cholangitis based on some laboratory values. After her diagnosis of PBC, she was started on appropriate weight-based ursodiol with 15 milligrams per kilogram per day. When you look at the laboratory values that are presented, before she initiated ursodiol, her bilirubin was 1, her AST and her ALT were in the 30s, her alkaline phosphatase was 350, so the pattern of abnormality that we see here is predominantly cholestatic. She had a positive antimitochondrial antibody. Her hepatologist did a fiber scan to evaluate the degree of fibrosis, which showed 11 kilopascals, and her liver ultrasound was normal. So after starting ursodiol, when would you decide whether to add second-line treatment? So, Dr. Bonder, in your practice and looking at this particular patient profile, when would you assess her responsiveness to ursodiol?
That's a great question. I think based on our current guidelines, I think we label someone as a non-biochemical responder between 6 to 12 months. But specifically in this case, there are certain kind of features that makes me think we should actually do it sooner rather than later. And specifically, we look, for example, the elastography or the fibroscan, as you mentioned. So I would say there are two kind of answers to this question. In a patient with really no significant liver fibrosis, it is okay to give the full year to see if there's a response. In someone who does have evidence of advanced fibrosis, like this case, I think doing it in this kind of around the 6-month time, it's a better timing for the patient.
Mm-hmm. The elastography measurements that you use to define high and low risk, are there particular cutoffs that come to that you are using?
Yes, I mean, based on clinical data that's being published by the global PBC, that I think both you and me belong, is we looked at a fibroscan or elastography of 10 kilopascals. That's kind of the threshold today on presentation that tells me that the patient is at high risk of kind of complication features in the future if we really don't act really fast. So again, on top of the alkaline phosphatase being one of the main thresholds, I think elastography is taking a big role in basically stratifying patients at risk of progressing and having complications of the liver disease if we really don't act at really early time.
Yeah, that's what we've been starting to do in our practice too, is really looking at that baseline degree of fibrosis and assessing response at 6 months instead of a year. So in this particular patient, after she was started on weight-based ursodiol, we evaluated response 1 year after treatment. And at follow-up a year after treatment, she did report some mild pruritus, which was a new symptom for her, but she said it wasn't really interfering much with her regular quality of life, her ADLs. When we assess laboratory values 1 year after treatment, we see that her bilirubin value stayed relatively stable. Her alkaline phosphatase improved from 350 to 220. And her FibroScan, her elastography measurements remained stable. They went from 11 to 10, so relatively stable. So she's had somewhat of a decline in her alkaline phosphatase from 350 down to 220. So definitely, over that 15% threshold that we think about. Her bilirubin is normal based on laboratory parameters as well. So when we have a patient like this who has a persistent elevation in the alkaline phosphatase, but at values of about 1.6 times upper limit of normal, does this person meet the definition of an adequate response to ursodeoxycholic acid, or do we have to really push therapy further for someone like this? And that brings us to the next big point, which is how do we define a response in ursodeoxycholic acid? And you can kind of see based on all of the various criteria listed up here that there's many different definitions to define response. But the thing to really take away from this is most of these definitions rely on an alkaline phosphatase threshold or a bilirubin value. Now, Dr. Bonder, what definition are you using, or are you using any of these in your practice to define a response?
That's a great question. I think that's one of the things that really varies between practitioners. Personally, I think maybe you're the same. I think the POIs have become kind of the gold standard that every clinical trial has been using to really label patients as responder. So again, the POIs actually label at 12 months is currently I would say the accepted definition of responders in kind of PBC world. So just to emphasize, the other scores are not that they're not being validated or used, simply is, I think, currently what's basically being used and all the new medications that were just recently approved is the POISE. So I think it makes it easier to really remember those kind of numbers.
Right. In order to start second line therapy in somebody that has, an incomplete response to ursodiol, you really define incomplete based on what the FDA has used to approve our second line therapy options, which is at 1.67 times upper limit of normal. In somebody that has a elevated elastography measurements, has some degree of fibrosis, do you try to potentially push the alkaline phosphatase values more towards normal, or is there benefit in doing that?
I think there's definitely them. I think the new normal should be completely normal. I think, there is data there you're going to show, proving this concept. Currently, what we actually have evidence is that getting that alkaline phosphatase below the 1.67 or below the POIL's threshold is our kind of current goal. You bring up a good point. We do have a fair amount of patients, but they have advanced fibrosis or elevated elastographies, which I think we should be pushing them get into normal because, again, getting that elastography to not getting worse or at least getting better has shown really improvement in clinical outcomes. So I think answering to your question, I do feel that there's certain patient population, there's certain characteristics that will make us think that patients with advanced fibrosis will benefit more with a actually improve or normal alkaline phosphatase.
Yeah, and I think that some of what you were referring to, the global PBC study group data, has really shown us that long term, following these patients 10, 15 years out, that the patients that have the best transplant-free survival are the ones that are really able to normalize their alkaline phosphatase and bring their bilirubin values down to less than 0.6 times upper limit of normal. So, pushing that threshold and redefining what our treatment targets are in PBC is sort of an evolving concept right now. I think that this data really shows nicely how the curves separate when you look at patients that have just an alkaline phosphatase that's between 1 to 1.5 times upper limit of normal and below normal values. And the biggest difference is really differentiating the patients that have fibrosis to begin with. So that have that, liver stiffness measurement over 10 kilopascals, we see larger separation in the curves. So especially in patients that have, I think, fibrosis, it's important to really push for those normal alkaline phosphatase values. We also presented some of our work with the target PBC cohort at AASLD this year and found very similar things, that if you are able to achieve a deep biochemical remission with normal alk phos and bilirubin values that are less than 0.6 times upper limit of normal, that there is true, reduced rates of decompensation and improved transplant-free survival in the US population as well. So I think that thinking about risk factors for the patients and stratifying what your treatment goals are when you assess a treatment response is going to be more of a personalized, individualized approach, but how the PBC treatment is evolving. So in this particular patient, Dr. Bonder, what would you do?
I mean, I think based again on everything that you've discussed. She has an elevated elastography. Her OCFOS is not at to the point that we can say that she's a responder. I think we can start thinking about a second line therapy. And again, when we look at second line therapies, I think you will all go over about different options. But I think this is when we basically look at the patient profile, patient symptoms, and kind of options that we have available to make sure that we treat either both or we don't have side effects leading to one or the other one. So I think it's so important to look at all those pieces of information before deciding what will be the second line therapy used.
Yeah. And just a reminder for everyone that all of these second line therapy options that are available, so obeticholic acid, which is an FXR agonist that was approved back in 2016, elafibranor, which is a PPAR alpha delta agonist, which was approved in June of 2024, so just recently, and seladelpar, which is a selective PPAR delta agonist approved in August 2024. All of these are not recommended in patients that have decompensation or Child's B or C cirrhosis. So really, exercising caution and understanding the degree of fibrosis and understanding any signs of portal hypertension or decompensation in our patients before we think about which second line therapy to start, if any, is important. So in someone like her who has some, very mild pruritus already, she has hyperlipidemia. I think there's certain, clinical characteristics of her that might lean you to choose one therapy over the other. And I think we can talk about some of the nuances with choosing second line therapy. Let's explore some of the efficacy and considerations for second line therapy. Just a reminder that obeticholic acid was approved back in 2016 based on the results from the POISE trial, which demonstrated significant improvement in biochemical response and alkaline phosphatase normalization. Just of note that in the study and in clinical practice, we do see that there is real-world evidence of treatment emergent pruritus, and that potentially being a reason for patients to discontinue the therapy. So patients that have baseline pruritus, it's really important to manage the pruritus before thinking about starting obeticholic acid and really understanding the severity of the pruritus before starting the therapy. Now, again, just remember that obeticholic acid is contraindicated in portal hypertension. So, assessing portal hypertension is important. So signs of thrombocytopenia, signs of splenomegaly on an ultrasound, anybody that has imaging evidence of varices that could indicate portal hypertension, but we would not be using obeticholic acid for those patients. Pruritus is a concerning side effect that could result from starting therapy with obeticholic acid, and it could result in a decrease in HDL cholesterol. Now, we'll talk briefly about the next second line option that was approved, which was elafibranor. So this was approved based on the positive phase 3 results from the ELATIVE trial, and it was approved last summer of 2024. Just a reminder that this was a double-blind placebo-controlled trial of patients that had an inadequate response or intolerance to ursodiol. Most patients in the study were on ursodiol, and you can see that after 1 year of therapy with elafibranor, 51% of patients achieved the primary outcome, which was the POISE criteria. And about 15% of patients had a normal alkaline phosphatase at the end of treatment. The considerations to note for elafibranor is that there is a fracture potential. So there was a difference in the percentage of patients that were randomized to the study drug to elafibranor compared to placebo in terms of fracture risk. So 6% in the elafibranor arm and 0% in the placebo arm. It's noted to really pay attention to any patients that are also on concomitant statin therapy, as there were a few cases of myopathy, and one case of rhabdomyolysis with acute kidney injury that was associated with elafibranor in a patient that was also on a concomitant statin. And then the other important thing to take into consideration is that there is teratogenic potential, and there's recommendations with elafibranor that any woman that is of childbearing age use non-hormonal contraception. There's also potential that with hormonal contraception, there's increased metabolism of it, and there is a possibility of unwanted pregnancies. So keeping that in mind for a specific patient population that might be starting elafibranor is important. And then lastly, we'll discuss seladelpar. So seladelpar was approved based on the positive results from the RESPONSE trial. This was similar inclusion criteria for seladelpar as there was for the ELATIVE study with elafibranor. You can see that after a year of therapy with seladelpar, that there was 61% of patients that were able to achieve the primary outcome, which was the POISE criteria, reduction to less than 1.67 times upper limit of normal, and 25% achieved alkaline phosphatase normalization after 1 year of therapy. So there was a significant improvement in biochemical response, and that led to the approval of seladelpar. The important considerations for seladelpar is that there was, similar to elafibranor, there was this fracture potential that was seen with seladelpar, and more to come as we start learning and prescribing this medication more. But about 4% of patients that were in the seladelpar arm had fractures compared to 0% that were in the placebo arm. So just paying attention to underlying bone health, treating potential osteopenia, osteoporosis, checking vitamin D levels for all of our PBC patients is important. So Dr. Bonder, knowing these considerations with second-line therapy, is there a particular one that you may prefer for her?
Again, based on what's the data they just reviewed, I think, both the elafibranor and seladelpar will be good options. She's on a statin, so that will make me more inclined to actually do seladelpar. And then with the itching, as you said, there might be a little bit more benefit to her symptoms. But again, I want to stress the importance that currently there is really no difference between those two drugs. So again, I think we will be stuck to what, unfortunately, insurances will let us know what we want to use. But I think from that perspective, I think, any of those two medications are kind of fair game and really good options to use as second-line therapy.
I agree with Dr. Bonder that as she is of childbearing age and she's also on a statin, it kind of leans me more towards using seladelpar. The obeticholic acid, I would maybe shy away from initially because she does report some mild pruritus now. We haven't quite controlled that yet. So I would probably prefer seladelpar and someone like her. And Dr. Bonder, are there any key take-home points that you would like the audience to know?
Definitely, we do have some key take-home points. Number one is we need to understand that up to 30-40% of patients with PBC do not respond to the kind of first-line therapy, UDCA. In those cases, non-response means not achieving an alkaline phosphatase less than 1.67, or as you said, the POISE data. The third one I want to make and emphasize is the use of elastography or FibroScan as kind of staging and also following the degree of fibrosis over time, which have been shown to be a key factor in managing patients with PBC. The fourth case take-home point is we do have good approved second-line therapies. We discussed the FXR agonist, we discussed the PPAR agonist, we discussed the pros, the risks, the benefits, as well as their side effects. And finally, it is so important to discuss kind of the potential risks and side effects of those medications with patients when they come to see us.
So I agree with all of your key take-home points. I think it's an evolving field, and there's more to come with how our treatment goals change, how we risk stratify patients going forward. I think one of the other biggest considerations when we think about treatment goals for PBC, the first is obviously achieving adequate biochemical remission, really preventing the progression of disease. And the other big thing when we think about our treatment for PBC is managing symptoms and quality of life for these patients. And that's another big area for us to explore. Thank you so much for joining us today. And thank you, Dr. Bonder, for your insights.
Thank you, and hope everyone got some really good information to use in your practice.
Thank you very much to Dr. Bonder and to Dr. Goel, and thank you to our listeners for joining in. For more programs like this, be sure to subscribe to the CCO podcast channel on your favorite podcast player. Thank you, and we'll see you on the next podcast soon.